My name is Leah Nelson. I am the newest and most embarrassed member of PARCA's staff. I know a lot of you in the room today, and I'm just so glad to be here. So today we've been talking about a crisis that requires solutions that come from people at every level of government and that are coming from the ground up, from the top down. There's international work going on, and there is local work going on. We've heard about innovation that's been empowered and enabled by regulators, by folks at the State House, by collaboration from agency heads. And in this panel, we're going to be hearing from people who are actually doing on-the-ground work. Because to get into recovery, you have to connect with someone. They need to see you. They need to talk with you, often multiple times. And that is really hard work. It's hard to get into recovery, and it's hard to help folks move along that path. Everyone on stage with me today does that work on a day-to-day basis. And so I'm going to let you all introduce yourselves, starting with Dr. Rutland.
Well, thank you so much for having us up here tonight, or today rather, Leah. I'm Dr. Will Rutland. I am an addiction psychiatrist based out of Montgomery, where I also serve on the faculty of the UAB Montgomery campus and have the privilege of running the residency training program there. But for the purposes of today's discussion, and probably the most fun thing I do, I'm the medical director of Alabama's first street psychiatry program, and it's a really thrilling position for me to occupy. So thanks for having me.
My name is Reggie Parker, just recently retired from the city of Hoover after 32 years of law enforcement. During that time, I became a licensed professional counselor, so I got both sides. I know it's a little different, law enforcement and counselor. I know it's a little bit different, but I do appreciate the opportunity to share my knowledge and experience of what I've seen on the street as far as administering or needing the education as far as Narcan application.
My name is Leah Leish. I'm a board-certified internal medicine and addiction medicine physician, and I run the Access Connect Transition Clinic at University of Alabama at Birmingham. I'm also the program director for their Addiction Medicine Fellowship.
I am Jonathan Riley. I'm a person in long-term recovery. My clean date is March 3rd, 2015. I just celebrated 11 years. I work with people engaged in recovery. I work with the OD2A grant. We're out here in the streets in South Alabama, in the rural area that nobody wants to come to some days, and we're hustling. We're working with people that that just want to be heard.
Well, thank you so much. I'm going to start with Dr. Rutland. So I had the really fun privilege of joining you around the corner from my house on your street psychiatry rounds a couple Wednesday mornings ago. We were with some medical students. This was a really interesting way to start my day. I'm going to try and come with you again. Listening to you ask your students questions to draw them out throughout the morning, you asked one, or I guess you asked the group, why would a person use crack cocaine? That was such an important question, and I want to just sort of pull on the thread because you were trying to get all of us to think about something. What were you getting at with that question?
Thanks so much for noticing that comment. I do think it's at the heart of some of the work we do in substance use disorders. And I'll be honest here, I'm coming at this from a psychiatric perspective. It is my belief as an addiction psychiatrist that all substance use disorders are a maladaptive coping mechanism for an intolerable internal mood state. That's a very wordy way of saying a person who is using substances feels something inside that hurts or that feels like a loss or an emptiness, and they address that by using a substance. And so what I was bringing to the attention of the students was that we can identify some of that pain, some of that hurt just by thinking about what substances are being used. So in this case, we were talking about crack cocaine. Of course, today we've talked a lot about opioid use disorder. And that gives us a little bit of an insight into the psyche of the individual, the human being, as opposed to just the pathology, which we can sometimes get caught up in. But there's a human being behind this that was having a human experience. And I wanted them to think a little bit about what was the predicate experience that led to the substance use disorder.
Well, Reggie, you were a first responder for a very long time. And you and I talked about how challenging it was as a first responder to incorporate new learnings about addiction as those became available, and as expectations changed, and social understanding changed of what was expected of you. And I'd really love for you to share what you saw and what it was like, especially as you were coming onto the scene as a first responder.
I think, first of all, there has been great work that has been done in this area. But as showing up as a law enforcement officer and arriving sometimes before EMS, I learned as being sergeant over the unit, had some pushback because of guys felt like there was a lack of education because we did some virtual training. And the concern was, and they didn't have the education, where does my liability start? Where does my liability stop? And that was some of the concerns. And my concern as a supervisor was hesitating when we know time is of the essence. And then some of the concerns were, where do we go next? Because I've shown up on scene and it looks different when I'm in a controlled environment doing a virtual training as far as when I was in the field in an uncontrolled environment, when I got a lot of different moving parts going on. People are looking at the uniform, they're upset with the uniform, and then when the medics sometimes have arrived, I saw them give the dosage, and it didn't work. And then they gave another dosage, and then they gave another dosage. I was unaware of that, but I feel like what everybody's been talking about up here today, if we continue to expand the education and the knowledge, we kind of understand what to expect. When I went into it not expecting to see that, and then it happened, it kind of took me back. And then what we are always taught is train, train, train. Well, I got one training, and then I think we need to bridge the gap together. And I like what I'm hearing here today, because I think the education has been up here with their higher, but what about the people in the field? I think we need to bridge that gap so we can actually understand what's been said, because a lot of good things have been said today. And I think if we can carry that all the way through, we can continue the great work that's been started.
Yeah, thank you for that. I'll say I ordered the Narcan kit from the State Department, and I keep it, but I really resonated when you told me that you weren't quite sure after you got the training what it would be like to give Narcan to someone. I'm not sure either. I've never used it. So I carry it, but I do have the same hesitation. What would happen? You know, would it be okay? So I hear you in saying, especially when we have first responders who are much more likely, I think, than I am to come across someone who needs it, that education piece and just making sure people are confident is so important. So the other Leah on the stage, hi. You work in what I understand to be the only or one of the only walk-in clinics where you can get, outside of an emergency department, same-day treatment for opioid use disorder in Alabama. Can you tell me about how that came about?
For sure, absolutely. So where I did my addiction training, we had a low-barrier buprenorphine clinic where people could walk in and get access to medications for opioid use disorder. So for those in the audience, to explain what I mean by low barrier, when you are someone who's struggling with addiction and you think, I don't want to inject fentanyl anymore. I don't want to do that. I want help. If you are not very familiar with the treatment resources, you might call a primary care office. They might tell you, we don't prescribe controlled substances. Then you call another one. You might get scheduled to visit a primary care doctor. That visit might be 6 months away. You might be part of the majority of patients with substance use disorder who do not have insurance. And so if you're part of that majority, then you're probably going to be trying to seek care from one of the sites that is funded by the SOR, or the State Opioid Response, or Strategic Opioid Response Grants that Commissioner Boswell mentioned. To get care through those grants, once you find them, you have to go through a certain process. That process involves getting an assessment. An assessment is this several-hour interview where they ask you about every substance you're using, what route, how often, what's your living situation, what's your family history, your medical problems. But it's a very long interview, and then you have to have an intake. The site that does the assessment may or may not be the same site that does the intake. And then you get enrolled in a counseling program, and then your counselor is the one that generally refers you to the doctor, who would then talk to you about the medication approaches to the management of opioid use disorder. And so the gauntlet through that process, even in an ideal world, at the time that we developed our clinic, was taking anywhere from 1 week to a couple months to try and get people in. And so you lose a lot of people, both just to follow up, but also to fentanyl. And so we said we really need to make this better. And we were working toward that in our clinic, but there were two main barriers. One was physician staffing. So at the time the X waiver still existed, only about 5% of physicians had an X waiver. Only about 1% of physicians were actively prescribing buprenorphine. So then trying to cover a walk-in clinic is difficult. And then the other barrier is finances, right? So you have to pay for this physician time, but you also have to find a way to pay for buprenorphine, which is expensive. And so we had a couple experiences in our clinic that made us push. We were working toward it, but decided to work toward it faster after kind of two sentinel events. One was a patient who had gone through the gauntlet, gotten enrolled in our counseling program, had gotten scheduled with the next available doctor visit, which was about 3 weeks out at that point, because again, you only have limited doctors and limited doctor time. We only had clinic open about 3 days a week at that time. And the counselor reached out to me after she had been in group for about a week and said, you know, look, this person's injecting fentanyl and she really wants to stop, and she cries in group about it. Can you get her in any sooner than her appointment 3 weeks from now? And I said, sure, send her to me on my next clinic day, which was like 2 days away. And when she arrived as part of our intake process, she discovered she was pregnant. And so it was exposure for not only her, but for her child. And she was very distressed about that, as well as we. And then there was another instance where my team asked me, you know, it was like 3 p.m. on a Thursday. We did not have a provider that covered Friday. And they said, hey, that's a friend of someone who's in group, and she's trying to get enrolled now. And if we hurry up with this assessment, et cetera, can you see her today? And I already had a bunch of people waiting in clinic, and I said, you know, I'm really overwhelmed right now. I can't see her today. You can put her on the schedule for Monday, because that's the next day we were open. And by Monday, she had passed away. And so we really just thought, okay, we gotta do it now. So we applied for one of the opioid settlement fund, the first cycle, and we were given an award to start that clinic. So now, Monday through Friday, 8 a.m. to 10 a.m., people can walk in. They will be evaluated for opioid use disorder and prescribed medications for opioid use disorder, if appropriate. And during our first 2 years open, between 2023 and 2025, we saw over 700 people from nearly 50 counties in Alabama, and we are able to connect over 80% of them to ongoing substance use treatment. And so it's been a great adventure.
Jonathan, you, the first or second time we talked, said, our story is our job for peers. And that is something that really stuck with me. We've touched on this already a little bit today, but we haven't really walked through what that first conversation is like when you are connected with a person in Dothan or one of the, 6 counties that you cover together with your colleagues. What is that first conversation like, and why does it matter that it's you?
For me, the first thing I ask them is I don't ask them why do they use, I ask them why do you want to get clean? What is your motive? What's your motivation? And someone will give me, of course, children, whatever else, job, whatever else. But I make them look deeper. Because for me, when I finally got done, like I said, my story is my job. When I was finally finished, I was sitting on that front porch out in East Texas, and the dope no longer worked, the alcohol no longer worked, and the only thing I knew to do was kill myself. And that old man walked across that pasture and sat down beside me, and he said, son, you want to die tonight or you want to live? I went and checked in detox, and I explained it to them. I'm like, I'm you, you're me. The only thing different between us is I haven't used today. And then I explained to them, life is just changing. That's what recovery is about to me, is being of service to others and about change. Because when I got clean, I said, you got to change. Well, what do I change? Everything. I didn't want to hear that. That's the last thing I wanted to hear. I mean, I still want to be able to go over here and hang out with these folks and do this, that, and other. But today I realize I can't do that. I mean, and I'm a person who believes in many pathways of recovery because I have seen people get clean through the many pathways of recovery. There's no patent on recovery. Now, I did grow up in the 12-step rooms. I still attend meetings. I have a sponsor. I do everything I'm supposed to. But for a certain person, they might need something different. It might be the MAT program. It might be the faith-based program. It might be the SMART program, whatever. I give them an option so that way they had the choice themselves. Because for so long, I never had a choice anyway other than use. And today for me, it's just, and to be able to look in their eyes, because I see them when they come back to me. When they come up to me on the street, like after about a year or two, because I don't recognize them. I mean, I'm 300 pounds now. I weighed 147 pounds 11 years ago. But I see them, they're like, hey, Miss John John. I'm like, all right, you got to tell me your name. I'm not recognizing you right now. And then they tell me. But then there's also the instances too. I lost my daughter 6 years ago. Everything I do for her. Remember. Because I never wanted to work in this field, y'all. I was happy doing what I was doing for a living. But when God calls you, God calls you. And I ran and I ran and I ran. But I've held so many mothers who've lost their children. I've held my wife when she comes in from work and she's lost a client. Because this happens still, y'all. Yes, the overdose deaths are down. Thank God for the not locks on. Thank God for the state of Alabama, ADMH, and everybody doing what they're doing. But y'all are still there. And it's scary. That's the reason I answer my phone at 2 a.m. Because my job is 8 to 5, but my recovery is a 24/7. I don't mind people like self-care, self-care, self-care. I hear it so much, self-care. I'm like, I'm going to get it tattooed on my forehead so I can see it in the mirror every time. But the issue being, y'all, at the end of the day, I might be the last phone call they ever make. So that's peer support is the greatest of great importance to me today. Because, and I mean, I love clinicians. I'm married to one, of course. But but the thing is, everybody's got to work together and work on this as one instead of just, boom, 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 boom. It's all got to come together. And I mean, I'm grateful to be sitting here with y'all because most of the time my company keeps me down in Southeast Alabama with a muzzle on. Because sometimes I do get a little out of hand. But at the end of the day, we all have the same goal. And that's just to help another person. We're not here to save the world. We're here to talk to one person a day and see if we can make a difference in one person's life.
Well, I want to leave space for questions. But I'm going to put a question, and everybody choose your adventure. I'd like to hear from everybody up here either what is something that gives you hope as you proceed with this work, or what challenges do you see ahead? What would you do if you had a magic wand that could only apply to Alabama policy and practice. This is a very limited magic wand. What would you do with it? So, say what you want to say.
I'll talk a little bit about hope. That's a topic that I'd love to expound on just a little. Certainly that's something that we see every time we're out in our street psychiatry clinic, and so it resonates with me. I think that hope arises from people seeing solutions with the same purpose. So all those eyes looking towards the same goal. It's easy to see problems. We can all see problems, but even today, we've heard folks talk about seeing solutions, whether that's further implementation of peers, whether that's easy access to MOUD, whether that's better training for the folks who are on the front lines. Certainly in our street psychiatry clinic, we are an innovative approach to that last mile problem. We have this wonderful architecture around treatment that's really sprung up in Alabama in an admirable way, given some of the headwinds that we face. But then taking those innovative solutions and getting them to the person, resolving those barriers, being unhoused, unstably housed, no transportation, no insurance. These are things that have been insurmountable until this point, but now we're starting to see solutions. And I think that comes from excellent leadership at the top and excellent leadership at the bottom, and everyone meeting around those solutions. So that gives me hope.
I'm debating with the magic wand or the hope.
It's a really, really narrow wand.
I know. I think the hope is that continue to travel down the path of education in which we have started, because I think that's what's going to bridge the gap and to help people to understand the mission. Sometimes I think those of us who are out in the field were blinded to the mission, but being able to sit among people who are actually doing the work as well, and we come together collectively, I think that's what's going to make it work. And like what you said, we can't be in our own silos. I think when we all work together and share information, I think that's what strengthens the hope, because I think a lot of us operate in fear of certain things. And when sometimes, although we know fear sometimes is real, but sometimes I think we're operating when it's false evidence appearing real. But when we can actually come together, I think it builds our hope, and we can hold each other up and move forward and accomplish the goal.
So I'll take both, because Reggie said mostly what I was going to say about hope. I think with hope, the collaboration I've seen around this topic between healthcare professionals, policymakers, first responders, peers, the education system, everyone became impacted, and so everyone got on board, and that makes making change much more efficient. And so I'll address the challenge. I'm sure there's many. As someone, I actually work on the Rescue Standing Committee of the Overdose Council. And one of the big challenges that we fear is the next contaminant. So fentanyl was the predominant contaminant in the drug supply, a while back. And we know from predictions from what's happening in the drug supply in the Northeast that there are new contaminants coming. And I hope that we can prepare ourselves in a manner that we're responding proactively and not reactively. And part of what would need to be updated here in Alabama is to update that drug paraphernalia law to expand not just fentanyl test strips, but the ability to screen out other contaminants as well. And that'll take some of that collaboration to get that done.
You're talking about things like xylazine and...
Xylazine, dexmetamidine, metamidate, designer benzodiazepines. I mean, there's a milieu of new contaminants.
I'm going to take a point of moderator privilege for folks that are not familiar with this. What we're talking about is that for a very long time, pretty much any street drug that you would buy could also have fentanyl in it. So fentanyl test strips are a little item where you can test the illicit drug that you've purchased to see if it has fentanyl in it, because there are people who might want to use methamphetamines or crack cocaine, but they don't want to use fentanyl. There have come to be additional contaminants, other drugs that are just in the supply of people are not intending to buy them, but that is what they get. Right now, you can only legally own a fentanyl test strip. There are strips that could allow you to test for these other contaminants, but currently being in possession of them would be a misdemeanor. So that's a barrier that exists. Sorry, I just wanted to clarify that.
No, absolutely. I mean, and I think the intent of the law was maybe to, I don't know, I'll let a lawyer speak on the intent. Anyway, I know there's fear that people will seek drugs out, but I will tell you, at least from my experience in clinic, the number of patients that I have come that are like, I never wanted to use fentanyl. I wanted to avoid it. Because I knew from what happened in the Northeast and the other places where the contaminants hit first that people died from that. And so I didn't want that. And so I think there's probably the majority of people would be using that to not die.
Yeah.
Something, Leah, I imagine you're seeing in your clinic that we see in ours occasionally is even folks on the supply side don't know that the contaminant is in the product. Mm-hmm. And so it really is a risk that no one is aware of. And so having those test strips could really make a difference, just to make sure that people are being safe.
But the thing that we're seeing, though, also with the age bracket of 18 to 25, is the drug of choice for some of them is fentanyl. Mm. And that's a scary thought, to sit there and say, you're wanting to use, because they'll ask for the test strips. Well, I want to make sure it's got the fentanyl in it. And I just sit there in shock.
Yeah, I mean, it's one of the ongoing challenges, and this is, I'm going to close us out so that we can keep questions, but I think you named one of the ongoing challenges is that this is always moving and that harm reduction is key. But there is no silver bullet for addiction that is going to magically solve all of it. That's why everybody is in this room today, so we can figure out how to keep moving and make sure that people breathe the next breath, if that's all we can supply them with until they're ready for something else. I want to open it to questions from the audience before we take our break.
Thank you. First of all, thank you, PARCA, for putting on this conference. I had no idea this existed, and thank you, Regents, for inviting me to your table. Jonathan, appreciate you sharing your story of your child. I, too, share that same story, and it's always grateful to hear another parent share that, and I know how hard it is. Dr. Leash, I have a question for you. For people in recovery, I did not know about your clinic, and I know that you offer MATs for people that are coming in, and I love what you're doing. Have you done any research, or do you provide long-acting injectables as a MAT for people in opioid use disorder or opioid use issues that they need help with?
Yes, we do. What's that? Oh, sure. For the audience, we use terms to describe the medicine. There are 3 FDA-approved medications for the treatment of opioid use disorder. MAT, we call it sometimes MAT, which is medication-assisted treatment. Sometimes we'll also flex to calling that medications for opioid use disorder, more specifically to define that we're speaking of opioid use disorder, because there are FDA-approved medications for alcohol use disorder as well. And so we just like to clarify when we're talking about MOUD. So there is a long-acting injectable. There are actually 2 different varieties of long-acting injectable buprenorphine now, and we do use those in our clinic. Access is a bit more challenging than for the sublingual, just due to costs. I mean, right now, 1 month shot is around $2,000, so it's about $2,000 a month. We choose to eat that cost a bit in our clinic. ADMH, the SOAR grant does cover some of that, not all of it, but for some patients it's just the right thing to do. I think Dr. Wilson mentioned some organizations for practical or personal belief purposes will allow the injectable versions, but will not allow the sublingual versions. And so we make sure we get the injectable versions too. And it's just in case anyone in the audience is wondering or concerned, this is an injection that takes place in the doctor's office with the doctor doing it. This is not something that people go home with. It's actually quite painful, and so patients who are willing to get it are most assuredly willing to recover, because no one sits through that for fun. But yes, we do offer those, and I think they're a great option for some people. Yes.
Hi, I just want to piggyback off of what Jonathan said and what Dr. Rutland said. My name is Nicole Dossier. I'm the Executive Director of the Addiction Prevention Coalition. And, you were talking about younger folks. And I think that we've talked a lot about harm reduction today. We've talked a lot about treatment and recovery and the power of peers. And I do just want to go back to what Dr. Rutland mentioned, which is kind of the reason why, right? Asking that question, not what's wrong with you, but what happened to you that is causing you to want to cope in such a way. And so I just really want to uplift that comment, because that speaks to the power of prevention, youth prevention, community prevention, both in things like medication disposal, but also working with kiddos beginning in grade kindergarten, talking about decision making, talking about we can do hard things, like with your son. And the community engagement the Community Engagement Advisory Council does a lot of that committee, but I know with Brandon folks at the helm of the prevention providers, like we're working across the state to get to some of those healthy decision-making, healthy coping strategies, so that folks stop coming to you, Dr. Leish, because eventually maybe you'd like to retire, right? And so if we can get upstream in all of the ways that we mentioned, that's really how we get out of or forego the next crisis. And it's working because our young people are using drugs at lower rates than ever before. So what we're doing is working.
Any other questions? All right, thank you all, panelists. Thank you for your work.